Welcome to the Jerry Powell Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, we have another special guest with us today.
We do. We have another special guest. We have Angelo Volandes, who's coming here from Boston, from MGH. Angelo is a well-known researcher around the country, and we got to know each other a little bit during your bioethics fellowship and my palliative medicine fellowship, I guess. That seems like ancient history now, I guess. Are we old enough to be able to say that?
Ancient history. We were taking clinical effectiveness classes together and enjoying statistics.
So welcome. Thank you so much for coming and joining us today.
Thank you for having me. It's a real pleasure to be here.
So we usually start off with a song here.
I think Angela has picked one. Is
Angela
that right?
has picked a song, a fine choice. Johnny Cash, Folsom Prison Blues. I hear the train a-comin'. It's rolling around the bend, and I ain't seen the sunshine since I don't know when. Oh, I'm stuck in Folsom Prison, and time keeps dragging on. But that train keeps a-rolling, bound down to San Antone. All right, well, welcome to San Francisco from the other side of the country, and we are so happy to have you with us. We wanted to first, get a sense from you about what you're doing, and what you're known mostly for is video advanced care planning. And I think a question that's on a lot of people's mind is, why would you do this? How did you come to this idea? Why video, right? When all what's been done so far has been pen and paper and that sort of stuff.
Yeah, it's a great question. Don't you want to play with a video camera instead of a stethoscope sometimes? I'm walking around the hospital having a film camera.
That's why we have a bunch of microphones in my office right now.
This kind of looks like my studio, my editing studio here.
We're moving in your direction. So far, we moved from blogging to audio.
Yes. I guess the next step has to be video.
The next step in our evolution would be video, but I don't think anybody wants to see us. No. They may want to see you, though, Angelo.
I even dressed up. I thought this was going to be video. I had my tie, my jacket, looking for, a little audio and visual. No, but the idea of the video really came through residency. I was admitting patients, and a lot of times I was asking myself, what are we doing to some of these patients, especially patients who had advanced illnesses and hadn't had conversations. So one particular patient that I started having my conversation, she had an advanced illness, and it was clear to me that when I was talking about goals of care, she didn't really have an understanding. And so I asked her, would you mind taking a tour with me around the hospital? And of course, she agreed, and we didn't walk. I put her in a wheelchair, and I took her around the hospital to the ICU. She got to see a patient on a vent. And as fate would have it, she actually witnessed a code.
Wow.
I brought her immediately out of the ICU, but she got to see what CPR looked like. And we went back to her room. We had a very different conversation. It was clear that the visual had helped her in a way that words clearly didn't. And obviously, we can't take people on tours. And that's really when I got the idea of using videos. Now, I should also, a little confession, during med school, I studied film. So I took some time off to study film. So it was kind of natural to meld the two. And from there, I said to myself, why not take everybody on tours? Why not bring people to where it's at so that they get a better understanding as opposed to television where everybody survives CPR and everybody looks like George Clooney on event.
Right.
Just to summarize what I know about the studies that you've published is that it looks like adding video to advanced care planning significantly influences how people make decisions. Generally, people wanting less aggressive end-of-life care than if they didn't watch the video. Is that a okay summary?
Yeah, no, I think the first word that you said is adding video. So, a lot of times people think this is to replace the doctor-patient relationship, and I'm like, no, it's not to replace, it's to reinforce it. This is just an add-on, an enhancement. At the end of the day, what we want are conversations, not videos. But it just happens that videos catalyze the process. It gets people going. Our brains have been rewired where we want visual material. And what we find is that people are more informed with the video, And when they're more informed and they have an advanced illness, they tend to make decisions more towards comfort care, which is what we know from all these surveys, that people don't want to suffer. They don't want a prolonged dying experience. So they're more informed, and when they're more informed, they tend to make decisions towards more comfort-oriented care.
Now, I have read your book, which is a fantastic book. We should plug your book. Name again is...
The Conversation, Amazon, Audio, whatever you wish, iTunes too.
And your website, which is...
So the website is acpdecisions.org, and there's actually some free videos on that in both English, Spanish, and a bunch of patient checklists in like 20 different languages.
And we'll have links to all of those on the GeriPal website.
Yes. Now, here's... now, I remember you had some examples of videos in your book, and I've seen some examples online, read many of your papers. Are there particular conditions for which video may be better suited or less well suited?
Yeah. So the things that we see day in and day out that people don't see, or that Hollywood doesn't see the way we see, dementia. That's clearly a big one. The advanced stages, we talk to our patients and they think of Ronald Reagan. Whereas we know in the advanced stages, it's someone who can't walk, can't talk, and feed themselves. Those sort of situations are really important to capture. Some that aren't, or that are just a supplement, are some of the PalCare conversation things that we focus on, like values. To start that, videos are good. They sort of help the doc or the nurse sort of have a checklist of things to remind themselves to ask. But, that could also be trained. You could train people to do that. But so when it comes to advanced illnesses, interventions is a key one. I was just over at one of the hospitals here in the Bay Area, and we were filming trach and pegs. I mean, I think if I was a daughter in an ICU trying to figure that out for mom, that could be a tough one. But to actually see and understand and what life is like in an LTAC facility, I think those are important to be captured on video.
So how do you think about this question of bias and when you're videoing something, how to make it both realistic, but I'm guessing every video you have a frame of reference, a potential bias, or an idea of what a good decision is. Your thoughts on that?
Yeah, so 2 points. The bias and then the good decision or the right decision. Bias is hard. If you watch Fox News, Trump won not only the Electoral College, but also the popular vote. Whereas if you watch MSNBC, we know the reality is he lost by 2 million votes. Look, the visual medium is an aesthetic medium. You could change and edit and zoom in on a patient who's intubated and have that saliva drool and have that breathing. Or you could do something that's more impartial. So we spend a lot of time, and we've come up with a series of criteria that people need to follow. Certain angles, having a narrator, not using testimonials. Even though we're narrative creatures, I could convince you if I wanted, with the right patient telling me a story of how they survived CPR, even though the statistics are that if you have an advanced illness, it's in the single-digit percentages. So we're very, very careful about that. But I make no qualms about it. The truth is, this is a biasing medium, so the best we can do is have lots of people review it. And I always say the end user has to view it, and that's people who have had this illness or the families. Now, your other question, which I am forgetting, was what's the right decision? That's right.
Yeah.
Well, the right decision is what Alex tells me is the right decision, right? No. Look, I mean, what's the right decision? It's what my patient wants once they're fully informed. What I hate is when I see my residents or my med students, the checkbox, did I ask the question? And I'm like, well, was it an informed discussion? So the right question is when people understand their options. And, I happen to feel that a video adds a lot of information, but at the end of the day, the right option is what my patient wants based on their assessment of the risks and benefits. But also, I mean, as a doctor, I think we have to make our recommendation. And, the most common question is, what would you want if this were your mom? I invite those questions.
So it must be an absolutely fascinating review process, because I remember looking at, we did a journal club. We've done I think 10 of your articles on Journal Club, but one of them was a video of someone with advanced dementia, and the big discussion was, did she look enough like she had advanced dementia, or did she look too much like she had advanced dementia?
It's a wonderful question. Oh my gosh. So that particular video, I get so criticized for it because let's face it, she looks really good.
She does.
I mean, she had rouge, she had pearls. I put the makeup on myself. Mm-hmm. She was being cared for and fed by her 3 loving daughters. That is not usual care, folks.
Yeah.
I mean, most people are. I actually, there are 21 Alzheimer's centers around the country, or probably more now. But when I made that particular video, I asked them to send me what they had about advanced dementia. And only one place actually sent me something. And it was a patient who was in her hospital bed filled with feces, in a diaper, and half naked. And I would argue that's probably more reflective of the reality.
Yeah.
And so what our group said was, let's show what the nicest version is.
Uh-huh.
And let's just see if there would be an effect with the nicest version. And with that first study, when we saw there was a tremendous effect in decision making, we said, wow, could you imagine what it's really like if people actually saw it? I also get criticized for this by a lot of docs when I give a talk and they watch our CPR video. They're like, where's the blood? Where's the gore?
Right.
I tell people, like, this is not about gratuitous violence.
Yeah.
It's more like a drug study. Start with a maximum dose, see if there's an effect. And here we are showing the nicest possible situation, never show blood, and see what people think about, or what do they think about the video? But is it palatable? How does it influence their decision, their knowledge, anxiety, depression? And I say, if this is the best of all worlds and people still make decisions towards comfort care, could you imagine what the reality is like if they saw it for real?
I've heard the criticism of some of these videos, not just yours but others, and this concern about bias. And there's a little bit of unfairness to that, I think, in that our language is often biased. And I have heard docs say things to patients like, if you have CPR, I'm going to have to crack your ribs. May have to cut open your chest and massage your heart, which is ridiculous because that hardly ever happens. I've heard them say things like, do not punctuate the end of your life with this senseless act of brutality, right? So there is certainly framing bias in the language we use, and yet the most common conversation out there is probably like, if your heart were to stop, do you want us to restart it? Or something horrific like that. So there is, we have to recognize there are limitations to the language we use, and there's certainly propensity for bias there in many different directions. Video, what you're proposing to do is rather revolutionizing the way we approach advanced care planning and having standardized videos for whole populations. And that's where it becomes critically important that, as you do, we take a really thoughtful, measured approach to deciding on the videos which we show to thousands and thousands and millions potentially of people.
Exactly. It's more of a quality issue. Look, every time I'm on service, I have my med student and my residents, and we play the newlywed game. We all go into separate rooms, and I sit down and it's like, I'm a patient with advanced cancer. Let's have the conversation. And I usually get my medical students say, well, patient, Mr. Smith, you don't want me to gently push on your heart if your heart stopped beating. Whereas my intern's like, you don't want to crack, I don't want to crack your ribs or anything. And then my senior resident is always like, well, if you have VFib, do you want us to? And I'm like, VFib, what are you talking about? So, this idea of biasing, I think our language is far more biasing, just like you said. And I would actually have more comfort in a standardized video that's been vetted by people, that's been studied, over a decade's worth of research, so that, even if you're a good doc having this conversation or a bad doc, at least the patient doesn't suffer and the family gets some information in a standardized fashion. And you're exactly right. This is where, PalCare systems information, systems thinking comes into play, because now we're talking about, can you take this to scale? And that's where it gets interesting, because, you could train one doc, one nurse, one provider at a time, or you can try scaling video, which is cheap. It's cheap, totally cheap. But you can start influencing on a large scale people's information and how docs start behaving. One of the best things I've noticed as a provider in my own hospital is now physicians, residents, med students start emulating what they hear in the videos and seeing that in their records. Now, that's behavioral change. But then having patients and families start using the language and start asking their providers, sort of flipping the dynamic and the power structure.
That's great.
Now, you just published a study showing that you scaled this intervention in Hawaii. Is that right?
Well, Hawaii, it's been 32 trips. 32 trips in 3 years.
Good place to scale your intervention.
I have to do research in Hawaii too in the future. Don't I? NIH? Yes.
Or some podcasts.
Right, podcasts on the beach.
So, look, Hawaii was an amazing, it just happened to be one of those opportunities that just come around and you had nothing to do with it. The Blues Cross of Hawaiian Medical Service Association, had read one of our, we were covered in a magazine, I think, and they called me up 3 years ago and they said, do you mind coming and give a talk? And I was like, yeah, hell yeah, I've never been to Hawaii. And so I gave the talk, but it was unusual because it was in the executive suite of a corporate building. It wasn't a bunch of docs. And I'm like, this is weird. So I gave my usual talk, and the one of the C-suite folks said, would you be willing to make the conversation the standard of care here in the state of Hawaii, by using videos? And I'm like, Hawaii's pretty nice, sure. But what we did is we tried to scale it so that we not only hit hospitals, but we went to clinics, outpatient practices, specialty clinics, but then we started going to churches, synagogues, elderly housing. We started going on television, radios. So over the last, let's see, the paper that you read was the first 18 months where we looked at 42,000 covered lives. And what we saw was an increase in documentation, hospital inpatient by 40%, increase in hospice discharges by, I think it was 22%. But also, and this is, I don't think we included this particular one in that paper, a decrease in hospital deaths by 22% for late stage patients. And that's incredible.
Yeah.
But it wasn't just, let's have the conversation when you're about to get tubed in the ICU. It was also, let's bring it out to churches, out into the community. Let's get the community involved. But it also meant different videos. So our videos is my wife, who's an African-American narrator. And we didn't think that would work in Hawaii necessarily. So we used the chair of medicine at Hawaii, who looks a lot more Hawaiian. And so we refilmed a lot of the videos. And so we also did it in different languages, which is key because you want to meet the end user where they're at.
Right.
And these weren't just like Google Translate. They were adopted and adapted. And so in Hawaii, it was Chinese, Cantonese Mandarin, Vietnamese, Korean, Japanese, Marshallese, some of the minority languages as well. And it's been a fascinating understanding because, even though it's about PalCare, it's also about QI. A lot of this was just quality improvement stuff. So it's been a fascinating experience. We're still, not complete in terms of the entire state. But right now, anybody in the state, 1.4 million residents, have access to all of our videos. And it's now the standard of care for most healthcare settings in Hawaii.
So I presented one of your articles at the American Geriatrics Society meeting last year. I think the biggest question that I got was, how do I get these videos?
Yeah, so we created a nonprofit foundation that just does this. I'm more of my responsibilities at MGH are all the research. So what we did is, for the masses, for everybody, we have free videos that are readily available, and they're free videos that anybody anywhere can use, but you can get started with the process. And it's our 5 most common videos, which is, how do you have the conversation? What is palliative care? Because we think that there's too much misinformation about that. About pulse forms. Also about palliative care. How do I talk to my doctor? And so those are freely available. It's also in different languages. And people could just go to the website and use those as they wish. For places that have a infrastructure where they've taken this on, then we ask them to license the videos through our nonprofit. That's how we sort of keep going and make more and more videos. But for, I would say, 99% of places, all they need to do is use the free videos and start the process. And, we have them out there. They've been available for the last few years and in different languages.
That's great. What's ahead? What's the next step? What's the future? Where are we going here?
So there's one of the hardest things for me is talking in an audience and getting NICU nurses coming up to me and say, why aren't you doing this in the neonatal ICU? And I was like, NICU? I haven't been there since third year medical school. What do I want to go there for? And that's where it was fascinating. Pediatrics, the variability in how this is occurring in pediatric populations, whether it's for the extremely premature infants or pedi-onc, that's where I think this really needs to occur, because there just isn't enough standardization. And so we're focusing now on pediatric populations as well as caregivers. So not creating videos just for patients, but for the sons and daughters who are making these decisions. For example, we were just working on a video to help, say, the daughter of mom who's got advanced dementia or advanced heart failure, and they now have shortness of breath. How do I know when to take my mom to the doctor or to the emergency room versus trying to do some simple things at home that might be able to alleviate some of the symptoms? In terms of the research, what we've done over the last decade, it's been more of randomization at the individual patient level, whereas now it's at the facility level. So now we're doing large pragmatic trials. Our biggest one is 600 nursing homes. Half of them get usual care. The other half get our suite of nursing home videos, and looking at about an N of 100,000 now, using MDS database and CMS data, looking at what happens to rehospitalizations, interventions, and stuff like that, which is really exciting, because I know that's the sort of stuff that gets you going as well.
Yeah. Oh, that's amazing.
I'm just trying to figure out how this works as far as a workflow in the hospital, at least for a hospital.
It's all done differently, and I think you have to be respectful of the local medical milieu before you say, this is how you do it. So some places have the nurses, during the intake on the floor, they do it. Other places have the docs show it. Other places say, hey, this is an interdisciplinary thing. It's not the purview of just the docs. We're going to have our social workers do it. Yeah. So it all depends. And most of the places, it's an iPad, or a tablet. Not on the TV, which is like 12 feet away, but, it's very, very powerful. When I use it with my patients, I have it on an iPad. It's a few inches from the patient's face. Often I'll have a family member sort of scooch in with mom on the hospital bed, and it's a powerful experience. I just sit back and observe them. I don't watch the video. I look at them. So much of the information I get is just looking not at what they're saying, but at their body language.
Yeah.
And that's just powerful to watch.
Yeah, the nonverbal communication.
Exactly.
Yeah.
Did you see the JAMA IM article that came out yesterday on
Laura Hansen's
randomized controlled trial of
video advanced care planning for nursing home residents with advanced dementia, actually for their surrogates.
Absolutely. So it's for the surrogates. Both Laura and Susan Mitchell, the senior author, are my colleagues. They're Susan's actually my co-PI on 2 of our grants, and Laura is a co-investigator on one of those grants. And what I really enjoy is to see more people doing this, because I think it's important, because of that issue of bias, to have other people make all different types of videos. I think different frameworks, different perspectives, artistic choices, about colors, literally colors of graphics, or of the type of people that you pick, or who's the narrator. So I enjoy more and more people studying the use of video. Video's here to stay, folks.
Right.
I mean, we're on audio, but it's going to go video very soon. It's just our brains are rewired like that. So I invite other people to try to do this, and I encourage people to just try different things. Even though we have about a couple hundred videos now in 20 different languages, I tell people, do the same things we're doing, because you'll have a different take, and we have to see, because it's still it's a nascent field.
Yeah, and Rebecca Sidori in our group has her own video take on things. Prepare for your care.
Oh, so I think Rebecca's a pioneer in this. She was the first really to use videos in the advanced care planning context. And what I love about Prepare for Your Care is that, it's values neutral, but it walks you through in a wonderful way in a means that people with low health literacy can understand, vulnerable populations. It's just wonderful. In fact, most of my patients know about our site. And in fact, I'd say most of our videos include a link to Prepare for Your Care, because I think that is the way to scale something like this.
That's terrific. How should we wrap this up, Eric?
Maybe a little bit more Johnny Cash.
More Johnny Cash?
Just to finish us up.
Oh, yeah, this is my favorite verse. When I was just a baby, my mama told me, son, always be a good boy, don't ever play with guns. But I shot a man in Reno watch him die. Well, I hear that whistle blowing, I hang my head